We'll first have a presentation. We welcome on stage Mrs. Rastogi, Dr. K. Kannan, Dr. S. Murthy, and can I also invite our orator today, Dr. V. Kannan. First, we will have a presentation on Dr. Rastogi.
We have pleasure in inviting you dear friends. We have pleasure in inviting you for the Hormones 2013 program, particularly to Dr. Gopalakrishna Rastogi. Dr. Gopal K. Rastogi founded the endocrinology department at the Postgraduate Institute of Medical Education and Research in Chandigarh. He was dedicated to his profession and contributed in so many ways to the medical education and research community in India. Dr. Rastogi's many students have excelled in their profession and standing in the community throughout the world. Dr. Rastogi is commonly referred to as the father of endocrinology in India due to his extensive research and publications of many articles with the assistance of his many students. Dr. Rastogi was born in Jaipur, India, and completed his schooling and college in Jaipur and then at Meerut, UP. Dr. Rastogi obtained his MBBS at King George's Medical College, Lucknow in the year 1958. Thereafter, he completed his residency at the Maulana Azad Hospital in New Delhi and in the United Kingdom. Dr. Rastogi trained throughout the United Kingdom and obtained his MRCP in both Edinburgh and in London in the year 1961, and subsequently his fellowship at the Royal College of Physicians in London. Dr. Rastogi joined PGI at Chandigarh in the year 1964 as a lecturer and subsequently became a professor of endocrinology at PGI in 1970. The then director, Professor P.N. Chutani, and Professor Rastogi had a vision to initiate the first super specialty DM course in endocrinology in the year 1969. It is also a matter of pride that PGI was the first institute in India where the DM course was started, and that too it was endocrinology. During his regime, over 50 students were trained in endocrinology and they are doing exceedingly well. The department has many distinctions, including the establishment of the first radioimmunoassay lab in the country in the year 1965. Dr. Rastogi left PGI in the summer of 1978 for the United States, where he was offered a position for visiting professor at the University of Alabama. Despite this offer, Dr. Rastogi decided instead to settle in London, Kentucky, and established a private practice with his wife, Dr. Indira Rastogi. Dr. Rastogi practiced medicine in London, Kentucky until his passing in 2006. Even following his relocation to the United States, Dr. Rastogi maintained contact with the staff at PGI, his many students and his followers. Dr. Rastogi was married to Dr. Indira Rastogi and had 3 children, Dr. Punita Halder, Dr. Monita Chari, and Anuj G. Rastogi, who is a lawyer in United States. Dr. Rastogi was a prominent citizen of London, Kentucky, where his friends simply referred to him as the Doc. He was an avid golfer, enjoyed snow skiing, gardening, traveling, and his pet dogs. Dr. Rastogi left for his heavenly abode on October 7, 2006 in Madurai, Tamil Nadu, while visiting to attend a get-together of PGI endocrinologists, postgraduates and staff.
Thank you, Dr. Kannan. I have great pleasure in introducing the orator for the second Professor Rastogi Oration, which was endowed by Dr. K. Kannan last year in 2013. Professor V. Kannan completed his education in Chennai and in the PGI Chandigarh and in the United Kingdom. He obtained his MBBS in 1965 from Madras Medical College. He did his MD in medicine in 1970, his DM in endocrinology in 1973, his FRCP from Glasgow in 1984. He was the first senior professor of endocrinology at the Madras Medical College and one of the first trained endocrinologists in this state. He's a Commonwealth Fellow and he's been in practice since then. His distinctions include being an editor of the Journal of the Association of Physicians of India, the Indian Journal of Medical Research, the Clinical Endocrinology, Oxford, and the Journal of the Indian Council of Medical Research. He has over 120 publications. Above all, he is a pioneer in the field of endocrinology in this state. The Endocrine Society Tamil Nadu and Pondicherry is pleased to honor Dr. V. Kannan with this year's Rastogi Oration. May I request Dr. Murthy, the President of the Endocrine Society of Tamil Nadu, to first give the medal. And then, Sir Nadula, sir, please. And Dr. K. Kannan will give the citation and the plaque. Now we request Dr. V. Kannan to deliver his oration and before we start the oration, we request Madam Rastogi to speak a few words. After that, Dr. V. Kannan will deliver his oration. As is a custom in these orations, there will be no questions. Thank you.
Namaskar to everybody, the chair people. It's a big honor for me to be here, and I sometimes get a lump in my throat when I talk about my husband, so please excuse me for that. And I also feel honored that I am introducing a little bit personal information about my husband, because most of you have not met him or known him personally. There are very few people here that they knew him personally, and I know how much regard and gratitude they feel for him, which makes me very, very feel honorable and with gratitude to them. And also I'm feeling very thankful to them for bringing me up here and speak to you all, and just to let you know what kind of a person he was. He was a very dedicated person and would fight for his rights and fight for the specialty that he was working in. He never intended to be an endocrinologist, but everything in his life happened very accidentally. He got interested in the study of brain and enjoyed working with the neurology department, and applied for a senior position in neurology in England. But for some reason, he was not able to get to that position, so they offered him to work in endocrinology, which he hated at the time. But he said, let me have a chance. So they gave him a temporary job for 6 months, and he started and fell in love with endocrinology and worked at different institutions for a while in England and came back to India. His heart was always in India. He didn't want to settle anywhere. And the first opportunity came was a lecturership at PGI, which he got right away because there were no endocrinologists in North India at the time. Of course, in South, you have had diabetologists for a long time. And within 6-7 years of his hard work, he attained the professorship and led the department in many, many different ways. But it was all because of his own personal boldness. He was very bold, and once he decided what he wanted to do, he would really complete it with any kind of energy. I don't know where he got that from. And always loved his students and everyone in department, whom he still, till his death, he had called that they are my family. And that was the main reason we came to Madurai when he was very sick. And I objected. I said, please don't go. We have to stay in Bombay and fly back to US. But he said, no, my family is there, and I have to be there. And also my mother Parvati is there, who would take care of me. So that was the boldness that even during sickness he wanted to be there because he had committed to them. And the other thing about the boldness, you would realize that he was holding a first Asia Oceania conference in Chandigarh in 1973. There was a lot of objection from the authorities. And finally he told them, I'm taking you a challenge and I'll prove it that this is going to be a very successful conference, which he did it single-handedly. There was nobody else in the department at the time, and because his associate had gone to US for one year. Then there's another evidence of his very greatness, openness, and boldness. In 1970, he went for interview for professorship. And in the interview with the selection committee, somebody said something which he was not aware of it. He stood up and told the chairman, he said, if there is some report against me, I want to know who has done this. And one of the professors in Chandigarh who did not like his boldness had written a wrong and bad credential report just because he was too bold and stood up for everyone. He stood up and walked out and telling them, you keep the job and I'm leaving. And came home and he said, pack up and we are leaving right now. I don't want to stay here. And then the selection board chairman, he said, this is the young man I want. And they called him personally, came to our house, took him back, and that's how great and his boldness was, That he would sacrifice his life or career just because, somebody has insulted him and his profession. And I think that is the dignity he has passed on to his lot of students. And I am very, very happy and proud that I see all those students who went through him. They would have been selected just because he worked with my husband, Gopal Krishna Rastogi. And they have kept that standard, and they have done very well, and they're very well known in India, in their own state, as well as internationally, because a lot of them, they do have international practices too. So that is a big thing that I would like people to know, that unless he was, if he was not aggressive and bold, outstanding, he would not have achieved, and India may have lost a department of endocrinology, not just in PGI, but whole India, because he gave respect to endocrinology, and with that, endocrinology became a super specialty little later in India, but it did come over. And after this DM degrees, everybody in India became aware of endocrinology, and several other institutes now later followed and produced DM students, and especially his own students, when they started DM program, he was very proud that my children are doing this, they have followed my tradition. So that speaks very high of a person to appreciate his followers and give them equal respect, not as students, but as a fellow and colleagues. So that is the major quality that everybody, I think, has appreciated. And I don't think I should talk more. So I think I have just introduced him a little bit. There are too many things that I could go on, but there's a time limit to everything. And now, finally, I'd like to again show my gratitude, especially to Dr. Kannan, both Kannans, Dr. Jayakumar, who's here, and I don't think there's anybody else here, but whosoever is associated with organizing committee and in the audience, thank you very much to you.
I take this opportunity to thank the organizers of Trendo and also to the Endocrine Society office bearers for giving us this opportunity to continue Professor G.K. Rastogi's orations through successive years of Tamil Nadu Endocrine Society meetings. I thank one and all. At this moment, I would like to show my gratitude to two of the people. Mrs. Rastogi, I wish to present two of my books. One is the trilingual expression of Tirukkural, which has got relevance, and second one is the Thiruvilayadal, the geography and history of Madurai, given in the form of an English drama to Madam Rastogi. The same two copies of my books will be also presented to Professor V. Kannan, who probably missed out on these volumes because he could not attend the first meeting at Madurai.
Thank you.
Now over to Professor Kannan.
Respected Chairman, Professor Kannan in Madurai, Professor Murthy, Dr. Krishna Seshadri, and Madam Rastogi. Thank you very much for this kind bestowment of the Professor Rastogi Oration today. I congratulate the Endocrine Society of Tamil Nadu and Pondicherry and wish them all great success in the years to come by making it a strong society of endocrinology in the country and abroad. Professor Rastogi, who just listened to the introduction by Madam herself, worked at the Royal Victoria Hospital, Belfast, along with Sir Montgomery and Welburn. Most of you go through the library, there is a textbook of endocrinology written by Montgomery and Welburn and Rastogi. Subsequently, he was associated with Hammersmith Hospital, Professor Russell Fraser, who came all the way to Chandigarh and spent the summer vacation in organizing a department and arranging the exchange fellowships between PGI and Hammersmith Postgraduate Medical Institute, London. He, as the head of the Department of Endocrinology, was a very renowned scientist in the country. He organized the department, as you have heard, the DM courses. He organized the World Health Organization recognized endocrinology laboratory in Chandigarh, PGI. He was involved in a number of original researches. Earlier research he concentrated was on pro-insulin content in pancreases of our Indian citizens, which was published in the British Diabetic Journal and also in the Journal of Clinical Endocrinology and Metabolism. He had held high intimacy with the pharmaceutical industry and introduced glibenclamide. In those days it was known as HB419 in our country first by his scholarly appraisal of the drug. He founded the Endocrine Society of India himself with other 6 members in 1970, of which we are celebrating the 50th anniversary this year, again in PGI in the month of November. So we thank his vision, and all his students, as the DM students and PhD students, have taken up high positions abroad as well as in our country. I was involved with him in arranging certain meetings and certain ICMR programs. In Tamil Nadu, he funded the program for diabetic research in insulin levels. He also funded the program for thyroid studies in Tirunelveli district. He organized the Asianic Congress, as Madam highlighted, in 1974 and in Singapore in 1978. In New Delhi, the idea of Congress in 1976. He has delivered a number of orations in our country, the ICMR Scientist Awards, High Scholar Award, Developmental Award, plus API orations, and we remember him for his kind contributions. One of the earlier contributions in 1973 was his interest in thyroid disorders in pregnancy with Professor Devi, the HOD of Obstetrics and Gynecology in PGI. He published this paper in the American Journal of Obstetrics and Gynecology to set up the normal values of T4, T3, TSH, and Professor Dash was sent to Michigan to work with Professor Midgley to continue these hormonal changes in pregnancy. I was involved with him in the publication of the second half of the article, that is the plasma TSH and the TRH responses in normal pregnancy. We found a little subtle elevation of TSH in those days itself, which has been cited for the last 20 years in most of the workers in this field. Coming back to Madras Medical College, we found out that in Madras, the thyroid patterns are different from what we are seeing in Delhi and Chandigarh. In 1982, we published the paper from Madras Medical College about the prevalence of high thyroid autoimmune disorders in Madras. High thyroid antibody positivity was seen. It was present, yes, in every trimester of pregnancy and continued postpartum. You can see the levels of thyroid microsomal antibody TPO, thyroglobulin antibodies during each trimester, which take an added in the last trimester with a rebound increase in the postpartum levels. We were interested in continuing this work, and about 30 new patients we see even today coming to our clinic with thyroid disorders complicating pregnancy itself. We can assess them by using clinical signs like ultrasound, by laboratory parameters, or special investigations like TRH testing. We must realize that the disorder is very, very common and remain undiagnosed, even now. Tamil Nadu, as you are aware, is an iodine well-off state, some compared with other states with iodine deficiency disorders in the north. The urine iodine excretion rates here is about normal for the accepted WHO terms in our people. Even then, the Universal Iodine Supplementation Program was started by the National Goiter Control Program, and recently our Chief Minister has strengthened by launching this iodized salt at a cheaper rate for all our public distribution system. Gestational hypothyroidism means thyroid disorders first detected during the development of pregnancy. It can be symptomatic and overt, which every physician will recognize and start treatment early, or more commonly, more than threefold rise is about subclinical states. Unless you target it and screen, you will miss the diagnosis. Asymptomatic thyroid antibody positivity is highly prevalent in our state, so my talk will only highlight this portion of the gestational hypothyroidism. All of you are aware the normal thyroid functions change during pregnancy. The maternal thyroid hormone production increases by about more than 30 to 50%, but the mother is able to adapt by raising the serum thyroxine levels to 30% more than the pre-gravid levels. Usually they range from 13, 14.8 and 15 during each trimester of pregnancy and come down after child delivery. The TSH levels level a very subtle elevations. Unless you have a very fine-tuned ultra-generation assays, the milder changes you will miss in the routine assessment of TSH levels in ordinary endocrine practice. Yes. We have been following these patients with thyroid disorders in pregnancy by doing this thyroid panel assessment with sensitivity of T4, T3, and microsomal antibodies. Positivity is taken with sensitive text assay kits imported from Europe. Thyroglobulin antibody test is earlier were done by hemagglutinin test, now currently by ELISA tests. The commonest cause of autoimmune thyroiditis is the most prevalent disorder in Madras. About 90% of them will have asymptomatic involvement of the thyroid with positive thyroid antibody states. In certain pockets of the state, we still have certain iodine deficiency complicating pregnancy, so we have to supplement iodine plus iodized salt itself. Rarely we see some complication of familial thyroid disorders or as deficiency of iron and selenium complicating thyroid functions. In this slide, I have summarized 300 patients we have seen from 1993 for 10 years in our clinic who had positive thyroid antibody states. You can see out of 300, peroxidase antibody above more than 50 units is positive in 76% of the women. In the first trimester, 80, second 77, and third trimester, 72%, relatively very high prevalence. After child delivery, even though it drops to only 44% of these women. TPO positivity persists. Thyroglobulin antibody positivity of 128 units or more is prevalent, but at a lesser level, but parallels the changes of thyroid microsomal antibodies. Both antibodies are positive in about 45% of our women with pregnancy. So among 300 women, 135 were positive in the whole group. Post-delivery, 48 were positive. This mouse is not working. Okay. Yes, thank you. The same positivity is shown in the form of a slide here, graphs in the first trimester, second trimester, third trimester, and whole group. TPO antibodies are highly positive, thyroglobulin antibodies are positive, and both positive in about 45%. Why I am highlighting this positivity is it is usually a benign condition. We don't go and give treatment for somebody who has just positive antibodies. But in pregnancy, it provides a number of complications in the endocrine system. Subclinical thyroid failure ensues in the first trimester itself, with 25% being positive with TSH elevations. In the second trimester, 37% are positive. You can see in this slide. At 8 weeks of pregnancy itself, the TPO antibodies start getting positive and then continue. Yes, thank you. The importance of positivity is shown here. In addition to being benignly positive, thyroid antibodies interfere with the thyroid function subclinically to produce high TSH levels, confirming subclinical hypothyroid state in about 88% of the women. Normal levels were seen in a very, very low percent, about 20, and suppressed levels was negligible. You can see in this slide, among the 300 women, TSH was elevated, about 400 TPO antibody titer positivity in 88%, thyroglobulin antibody positivity in 72%. This shown, the values are shown here in the whole gestational group after log transformation. You can easily see thyroid antibodies rise from 4 weeks onwards, go up to 20 weeks, and then but never come down to the normal range of the health. In health, it remains about less than 12 units. Not only they rise and fall during the third trimester, there is a rebound rise up to 1 year after child delivery. So much so, the postpartum thyroiditis autoimmune changes persist and can produce further complications in the mother with maternal hypothyroidism or transient thyrotoxicosis. We can predict if you follow up these women consecutively throughout the gestation, if first trimester if thyroid antibody is positive, you can tell you will really likely to have positivity of postpartum thyroiditis in hypothyroidism in 25%. Yes. Not only hypothyroidism is one of the important pathological sequences of thyroid antibody positivity, but also a number of other obstetric complications. this thyroid compromise recurs with miscarriages, recurrent in about few women. We have people from Delhi and in Bombay, VIPs, who had positive thyroid antibodies, but multiple abortions at 6 weeks, 8 weeks, 16 weeks. The family really got going into the legal tussle because of the problems of conception. In addition, gestational hypertension, diabetes, postpartum hemorrhages are quite common. We can see here. Miscarriages in the early trimester, toxemias were seen complicating thyroid antibody positive gestational hypothyroidism in about 17%. GDM risk was high, by about 4-fold. Anemia and iron deficiency hemoglobin less than 8 grams is seen about 1/3 of the women coming to our clinic. Postpartum, it persists. Gestational diabetes being, as when we came to Madras in 1970s, the obstetrician never believed diabetes is a complication of pregnancy. They said we will just manage diabetes as a normal diabetic patient. With work by Professor Seshaya and Professor Moses, they have established gestational diabetes is a very important metabolic syndrome complicating pregnancy. Then adequate guidelines have been issued for its management. In 50 patients with GDM, thyroid antibodies were negative in about 46% of the individuals, but were positive in 21 in 5 had thyroid antibody and TSH positivity. TSH elevation alone in another quarter proportion of patients. The GDM risk is increased by 4-fold if you have thyroid antibody positivity in the first trimester. Much more than the maternal health, the growing fetus also is influenced by the thyroid antibody prevalence in the mother. Some of the well-observed complications of the newborns are well known with the neonatal unit. Small for gestational age, prematurity, attendant with prolonged jaundice, and additional complications of child development itself provides a long-term burden on the mother. Congenital hypothyroidism may be associated. Autism and Mongolism, trisomy 27, we have children being followed up both in whole state as well as from Andhra Pradesh. In addition, we have a peculiar occurrence. We have reported this to many patients. There is a family which we have thyroid antibody positive even pre-conception at the age of 18. She delivered 2 children, so both of them had persistent atrial septal defects, unfortunately. They had to be operated at our Madras Medical Mission Pediatric Cardiac Center. They are doing well. They have now grown up by 20, but they have developed additional endocrine complications, not related to the thyroid, but with the ovaries. IQ lowering has been associated, is being debated whether we should involve earlier itself, the management with thyroxine therapy and so on. In fetal thyroid development, the antibodies cross the placenta and harm the fetal development of thyroid. The lower iodine pools of the developing fetus make it vulnerable for thyroid antibody-induced toxicity. They may be induced directly or by exaggerating the iodine deficiency prevalent in the mother, or due to thiocyanate overload or selenium deficiency, and cause progressive fibrosis and glandular destruction resulting in persistent congenital hypothyroidism. Rare gene mutations of the thyroid antibody genes have been reported, but we have not come across these gene mutations. Probably requires further molecular probing in our center. Commonly, we find the high estrogen levels rise the TBG and so on. They rise the TSH thyroid production demand, so maternal TSH level increases. Chorionic gonadotropin in the early phase of pregnancy also stimulates the thyroid. The placental deiodinases interfere with the thyroxine metabolism, so much so the TSH level rises. In pregnancy, the development of these thyroid antibodies has been investigated by many workers. The T cell regulatory changes have been analyzed. HLA studies we have done, but we found it similar in both positive and negative thyroid antibody pregnancies. So we suggested that it may be with Professor Amino in Japan. He is working on this for the last 30 years. He suggested so many other additional molecular mechanisms may be involved in this autoimmune imbalance. Thyroid peroxidase, as all of you know, is a microsomal antigen involved in the organification of iodine, coupling of DIT to T4, and releasing from the apical portion the thyroglobulin stored molecule incorporating the T4 and T3 levels. The TPO gene has been isolated in chromosome 2. It involved transcription of TSH interactions. Direct cytotoxicity has been shown in experimental animals. These antibodies, they go and damage the placenta and the developing oocyte, probably causing recurrent abortions in the early phase of gestation. In mice, immunochemical deposits of human TPO IgG complexes have been shown in the thyrocytes as well as in the placenta. Thyroglobulin antibodies, all of you are aware, thyroglobulin is a benign molecule which is essential for storing the hormone and releasing it as a endoskeleton for the thyroid metabolism. The thyroglobulin antibody gene is located in chromosome 8. It is also dependent on the TSH interactions. Thyroglobulin antibody blocks the T4, T3 synthesis. A number of investigators are now probing whether the B-cell activating factor F or T-cell factors, interleukin-4 or TGF-beta or transcription factors may be involved in production of these antibodies, why they get exaggerated. We found in Madras that thyroid antibody prevalence is much higher than in other cities of the country. Chandigarh and Bansali reported 6% in adult women, 31% during pregnancy, and subclinical hypothyroidism, and 52% post-delivery, 35%. In Mumbai, they're relatively low. In Sri Lanka and South Africa, all of you are aware, there is an international scheme going on. The prevalence is around 8%. Diagnosis requires correct targeted screening of the mothers each month of gestation. Probably starting immediately after pregnancy confirmation, it is better to screen for thyroid, just like we look for diabetes in the second trimester. Please look in the first trimester itself, the TSH level and the thyroid antibody positivity state. Most of the women who are in adolescent hypothyroidism, when they conceive, they come back to you for pre-conception dose adjustment. We increase the thyroxine dose in first trimester itself. The obstetricians are hesitant to increase the thyroxine dose in the early gestational periods. They think a fixed dose of 50 micrograms will take care of the maternal demands of thyroxine, but it is often insufficient. Every 4 weeks, monthly increase of the thyroxine total dose is suggested, 75 to 100 or 150. In few patients with severe hypothyroidism, the dose may go up to 200 micrograms. Up to 20 weeks, we increase the dose and see the plasma TSH level is maintained less than 2.5 milliunits for optimal thyroid development of the fetus. Here, the slide summarizes the correlation of thyroxine dose 100, 125, 150 to the TBG level, to the estradiol level, and the median TSH levels in the first, second, and third trimesters. Fetal thyroid is very, very sensitive, as we have seen, for the maternal disturbances in the iodine metabolism and thyroid metabolism. The thyroid production commences and starts functional independent of the mother by 8 weeks itself. They rise by about 10 micrograms a term. The TSH responses and T4 responsiveness becomes optional from 5th month to delivery. The T3 levels remain low in the fetus. Amniotic fluid T3 levels are low, whereas the conjugates of reverse T3 and T4 sulfate are increased. So much so, neonatologists now consider treating the fetal thyroid hypothyroidism pure diagnosed by amniotic fluid level lowering and thyroid antibody positive. The placental transfer alone may not be suffice, so please consider intra-amniotic injection of thyroxine, of serum thyroxine under continued monitoring. The fetus takes up the injection thyroid. So to summarize, I request the Endocrine Society of India to form a guidelines of managing the maternal hypothyroid state in pregnancy, just like we have GDM guidelines. It requires targeted screening of every mother, because at present, the obstetricians and general physicians, they miss about 80% of these severe metabolic disorders, which are asymptomatic, but we have severe pathological consequences. If you wait for development of goiter or wait for symptoms of hypothyroidism, it is all non-specific. So please confirm thyroid antibody positive in the screening test itself, in patients with subfertility or recurrent miscarriages or recurrent fetal loss or the toxemious pregnancy. And then please do the monitoring of the thyroid functions till 1 year postpartum. An optimized therapy with thyroxine dose individualized to maintain TSH levels at 2.5 units is very, very cost effective and is beneficial for the mother as well as the fetus. Here we have shown you illustratively what are the changes happening after delivery. Hypothyroid state persists with a rebound increase about 4 to 5 months after child delivery. And we have followed up these patients for more than 15 to 20 years. We find at 5 years, the hypothyroid state becomes permanent hypothyroidism requiring thyroxine therapy for life. So with this, I will conclude my oration and I thank all the organizing committee members. I remember Professor Rastogi and Professor Dash and my assistants. With thanks to all the physicians and obstetricians in Madras. Thank you.
Thank you, Professor Kannan, for quoting some of the important works of Professor Rastogi and the way he has been following it up with studies in Chennai. As endocrinologists, we all do recognize that one other important problem of pregnancy is thyroid dysfunctions, and particularly the disturbing antibody positivity. Many a times we control the thyroid perfectly, but because of the high antibody positivity, there is some miscarriage, some problem. We are unable to face the patients or explain to them the problem. He has very clearly shown us all the implications of the thyroid profiling during pregnancy and proper management. I think we have come a very far from the days when many people used to stop thyroxine thinking that it is a drug during pregnancy. So we are better off. Our gynecologists and obstetricians do cooperate with us. And I have a particular thanks to Professor V. Kannan for honoring us by presenting his oration in the name of Dr. G.K. Rastogi. Thank you so much.